All right. Good morning, good afternoon, good evening, wherever you are, and welcome to this session on the launch of the WHO report to estimate the impact of vaccines on antimicrobial resistance and use. It's organized by the World Health Organization with the support of TechNet. You can listen to this session in English, French, and Spanish. To do so, please click on the globe icon, which is at the bottom of your Zoom window, and select the language in which you'd like to listen to this session. Now I'm going to say that in French for our francophone audience. Bonjour et bienvenue à cette session. Vous pouvez l'écouter en français ou en espagnol ou en anglais. Pour choisir la langue dans laquelle vous voulez écouter cette session, veuillez cliquer sur l'icône qui est en forme de globe en bas de votre écran et sélectionner la langue dans laquelle vous souhaitez écouter cette session. Now, please allow me to say that in Spanish with my French accent. Puede escuchar esta sesión en español. Solo haga clic en el icono del globo terráqueo y seleccione el idioma en el que desea escuchar este seminario web. Back to English. We'd be happy to know who's with us today, as usual. So please introduce yourselves in the chat box and tell us your name and where you're from. You can also use the chat box if you have any technical issue. I'll be the one taking care of it. So don't hesitate to let me know if you cannot hear something or if you need anything, right? For the questions, as usual, if you're familiar with the TechNet webinars, you can ask your questions during the presentation at any point. Please use the Q&A box. It's available at the bottom of your Zoom window. We have colleagues here who will be pleased to answer those questions. Finally, this session is recorded and we'll share with you next week the links to the video as well as the slides by email, and perhaps this week if we have the time, it will depend. Anyway, we'll share the links with you. So we really hope you'll enjoy this session. I'm personally very excited, and I'll give the floor to Yvan. Yvan, the floor is yours.
Good morning, good afternoon, or good evening, colleagues, wherever you are. So my name is Ivan Houghton, and I'm Director of the Department of Surveillance, Prevention, and Control of the EMR Division at WHO headquarters. It's really my pleasure to host you and to host our main presenter and our panelist for this webinar that will be launching the WHO report on estimating the impact of vaccine in reducing antimicrobial resistance and antibiotic use. So I'm sure that this year you will have been hearing about antimicrobial resistance because during the 2024, AMR has been quite on the agenda. So why is it on the agenda? The easy answer is to say that there's an increased recognition of the burden of disease associated with DMR. In terms of purely mortality, the estimates that have been used for the UN General Assembly have been 4.95 deaths that are associated and 4.95 million deaths that are associated with antimicrobial resistance and 1.23 million that are more directly attributable to AMR. So that's a substantial burden of disease. But what's even more maybe concerning from a societal point of view is the economic burden and also the threat to economics and also, for instance, to food production and livestock. So for all of these reasons, there's been a number of events in 2024 that have reflected the interest of the global community to do something about AMR. During the World Health Assembly, we've had a resolution that has approved the WHO strategic and operational priority for the work in the health sector for the next 10 years. But zooming out of this, in September at the UN General Assembly, there was a high-level meeting that led to a political declaration that was universally adopted by the member state. Then that really show how AMR needs to be addressed, not only from a health sector point of view, but really in a One Health approach involving all the various sectors. And in the UN system, this is reflected by the quadripartite organization. This political declaration is really a progress over the last one we had in 2016, because there's a number of quantified target, maybe the most important of which being a reduction of 10% of the burden in terms of mortality by 2030. So that is really something that provides us a mandate to do solid work. Going back to the health sector, the conceptualization of the work of AMR has changed a little bit when I would say AMR became prominent on the agenda 10 years ago. AMR was mostly referred in terms of bugs and drugs, very much driven from a microbiological approach. Now we really talk about AMR much more in a primary health care for universal health coverage sort of principle. And WHO proposed what we call person-centered approach, which is quite straightforward. It's basically a foundation of governance and financing, then strategic information, including surveillance and research, and a number of pillars. One, which is prevention, which we're going to talk about today, that includes WASH, IPC, and immunization, a pillar of access to services, a pillar of a diagnosis, and a pillar of appropriate treatment. So if we see this person-centered approach within the prevention pillar, as I mentioned, we have WASH, IPC, immunization. The question is, if we want to reduce the burden by 10% by 2030, as we've been mandated by the UN General Assembly Political Declaration, what is the impact that we can expect from vaccines? So we needed some information to guide us in this area. And the Department of Immunization, Vaccine, and Biologicals has been leading this work, of which we will hear today. And really this modeling exercise that has been done help us to frame what we can expect with the vaccine that we have today, for which we would increase the coverage with more equitable and higher coverage. The vaccine we might have tomorrow, like TB vaccine, and the vaccine that ideally we would have in the future for things like Klebsiella. And so without further ado, I would really like to hand it over to my colleague and dear friend, Kate O'Brien, who is the director of the Department of Immunization, Vaccine, and Biological, for her own opening remarks. Over to you, Kate, and thank you for joining.
Yeah, thanks so much, Yvonne, and greetings to all of you. Good morning and good afternoon, and for some of you, good evening. Really, really happy you're joining us today. And I really want to, first of all, thank you for being part of this important webinar organized during the World Antimicrobial Resistance Awareness Week. As Yvonne just laid out, AMR represents one of the greatest public health challenges of our time, and it really threatens to undermine these decades of progress that has been already achieved in fighting infectious diseases. And it puts millions of lives at risk each year out into the future. So this is the reason why tackling AMR requires innovation. It requires a multifaceted set of solutions, and vaccines are a critical part of that strategy. So today, we're here to discuss the findings of WHO's recently published report that's entitled Estimating the Impact of Vaccines in Reducing Antimicrobial Resistance and Antibiotic Use. And the report provides you an in-depth analysis of the potential of 44 vaccines targeting 24 pathogens to address AMR, and doing that by reducing infections, minimizing antibiotic use, and curbing the spread of resistance. So 3 different approaches. And it's a comprehensive exploration of how we can better leverage vaccines to protect health systems and mostly to save lives. So just to give you a preview of the results, the report highlights some really striking findings, and I'm just giving you a taste so that you're really prompted to watch and listen carefully as we go through this session with you. So the highlights are that vaccines have the potential to avert up to 515,000 deaths annually caused by AMR. They could also reduce antibiotic use by 2.5 billion doses every year, accounting for 22% of the global antibiotic use. In addition, they can save $30 billion in hospital costs annually, which is a huge economic relief that is tied directly to reducing the number of people who get sick with drug-resistant infections. Now, we have existing vaccines like pneumococcal conjugate vaccine, which is already playing a vital role, but there is untapped potential. So for example, if we achieve 90% coverage for pneumococcal vaccines globally, we could avert an additional 27,000 deaths annually compared to the current use and current coverage against pneumococcus. There are also vaccines that are in late-stage development, like those targeting tuberculosis, and they offer incredible promise. Now, if they're introduced, they could prevent 71,000 deaths and over 1.2 billion antibiotic doses annually, also reducing the burden of AMR significantly on the TB side. So the report also explores the potential for new vaccines that are still under development. For example, a maternal vaccine that would target Klebsiella pneumoniae could prevent 27,000 deaths annually in newborns and significantly reduce the need for antibiotics. Those are just some of the highlights from this report. So what about a call to action? Well, it's clear that vaccines are really powerful tools in combating AMR, but we've got to do more to integrate them into the global strategies. So an example of a strategy would be Immunization Agenda 2030. This is the global, every country overarching strategy on immunization. And it does call for universal vaccine access, innovation, and strengthening of systems. So based on the findings of our report, WHO recommends expanding the use of existing vaccines to reach at least 90% coverage globally, especially for vaccines like pneumococcal conjugate vaccine. Secondly, accelerating the development and introduction of new vaccines, like those targeting tuberculosis disease and Klebsiella pneumoniae. And third, prioritizing research and innovation to address those pathogens for which vaccines really remain challenging to develop, like Group A strep. So we should really recognize these are not optional steps, they're critical steps, and vaccines must be recognized and incorporated as a core component of AMR strategies at the global, the regional, and the national level. So I really want to thank all of you, policymakers, researchers, health workers, health practitioners, for your commitment to addressing AMR. It's your collaboration and your dedication that makes this progress possible. So I really hope that today's discussion inspires some new ideas, inspires some new partnerships, and that these will accelerate our shared goal of combating AMR and protecting global health. So thank you so much for being here and to hearing more from all of you. Thanks so much. And I'll hand back to Matheus.
Thank you. Actually, I think in the master plan, I'm supposed to introduce Matheus, but thank you so much, Kate. Whatever works. Thank you so much for these excellent remarks, and thank you so much for the excellent collaboration. So colleagues, some of you couldn't wait for the slides, so good news, the slides are coming. And so now Dr. Matheus Agopsovich will be presenting the main finding of the reports with the slides that will now starting. So Matheus, over to you.
Thank you so much, Ivan, and thank you so much, Kate, for this introduction. I'm just checking, can you see the slides? Because they're on my screen.
Yes, we see them.
Perfect. Thank you so much. So thank you so much for these introductions. I am Matthias. I work in the immunization department at the World Health Organization headquarters in Geneva. And today I will talk to you about the report that WHO has recently published that talks about, says results as to how can we estimate the impact and what is the impact of vaccines in reducing antimicrobial resistance and antibiotic use. We published this report just a couple of weeks ago, and the reason why we wanted to have this webinar today is because of the World AMR Awareness Week, and during that week, we wanted to bring to your attention what the report was about, what were the key findings, and what is the call to action. What we had estimated and what we had found in this report is that vaccines have the potential to annually avert up to 515,000 deaths, 28 million DALYs, $30 billion in hospital costs, $20 billion in productivity losses, all associated with antimicrobial resistant pathogens. And in addition to that, they could also have the potential to avert up to 2.5 billion antibiotic doses annually. You can go to the link below where you can read the report in more detail. And in this presentation, I'll go through the context, the rationale as to why we conducted this analysis with partners, what is the methodology, and what are the key results, and lastly, what are the recommendations and the call to action going forward. So allow me to start with this slide that shows you what is the global burden of antimicrobial resistance. Ivan, in his opening remark, has mentioned the burden of AMR in 2019. We since have new data that is showing the burden of antimicrobial resistance for 2021, which has just been published a couple of weeks ago. And there we can read that in 2021, 4.7 million deaths were associated with bacterial antimicrobial resistance in 2021 alone. And you can see the distribution of these deaths associated with AMR across different pathogens on the graph on the right-hand side. And you can see that for the 6 leading pathogens for deaths associated with AMR were responsible for 3.7 million deaths associated with AMR in 2021. And these are Streptococcus pneumonia, Staphylococcus aureus, E. coli, Klebsiella pneumonia, Acinetobacter baumannii, and Pseudomonas aeruginosa. If we want to see where does this burden take place and look at regions, the highest of that burden is in South Asia, 1.3 million deaths associated with AMR, East Asia, 0.7 million deaths, Sub-Saharan Africa, 0.5 million deaths associated with AMR. I think the point here is that the burden of antimicrobial resistance is large. In order to reduce it, we need to have multiple interventions to tackle that burden, and vaccines could be one of the solutions to reduce a proportion of that antimicrobial resistance burden. Because of that, on this slide, I had highlighted that for the evaluated pathogens here, we already have vaccines against 4 of these pathogens: Streptococcus pneumonia, Mycobacterium tuberculosis, Salmonella typhi, and Haemophilus influenza type B. Some of them may not be yet introduced where they need to be. Some of them may not have high enough coverage, and some of them may not appropriately prevent from the type of infections that is causing resistance. And in addition to that, we also have 7 different pathogens for which vaccines are being evaluated, developed. These include Staph aureus, E. coli, Klebsiella pneumonia, Group B Streptococcus, Shigella, non-typhoidal Salmonella, and Salmonella paratyphi. So you can see that there is potentials for vaccines to take their action and prevent antimicrobial resistance. So how do vaccines do that? What are the pathways through which vaccines reduce antimicrobial resistance? Firstly, vaccines prevent infections both with drug-susceptible and drug-resistant pathogens. They can prevent you individually from becoming sick from a resistant infection with a resistant pathogen. And if sufficient number in communities are immunized, they can also prevent those who are not immunized from getting sick. What vaccines also do is by reducing the incidence of drug-sensitive and resistant pathogens that are causing infections, they decrease antibiotic use that is normally associated with treating infectious disease. If you don't have an invasive pneumonia infection, pneumococcal infection, you do not need to take antibiotics for that infection. Therefore, you reduce the need for that antibiotics. And by reducing the number of infections and by reducing the number of antibiotics that you need to treat these infections, you reduce the chances of developing resistance genes, evolution of resistance genes. And you also decrease transmission of resistant pathogens, which promotes drug resistance. So we see that the burden of AMR is large. We understand what are the mechanisms through which vaccines could reduce a proportion of that burden. And increasingly, the role of vaccines in reducing antimicrobial resistance has been integrated into AMR-related strategies and even very briefly introduced what is a people-centered approach to address antimicrobial resistance in human health, which is a core package of interventions from the World Health Organizations as to what people, colleagues at the country level need to do in order to develop national action plans on antimicrobial resistance, which are country strategies to tackle AMR. And within these plans, what are the actions that they need to take in order to reduce AMR? This people-centered approach includes 4 pillars, and pillar 1 is prevention. And within that pillar 1 prevention, there is an 8th intervention which calls for access to vaccines, which calls for expanded immunization to manage antimicrobial resistance, which also includes development of new vaccines. In addition, what we had done in the immunization department together with colleagues from the AMR division, we wanted to zoom in on vaccines particularly. And what we had developed is something that we called an action framework to leverage vaccines to reduce antibiotic use and prevent antimicrobial resistance. This is a set of actions that stakeholders need to take on in order to fully leverage the role of vaccines in reducing AMR. And these actions that are targeted at pharmaceutical industry, researchers, academia, members of international organizations, etc., and are centered around 3 categories. The need to expand the use of licensed vaccines to maximize the impact on AMR, like the need to expand the use of pneumococcus vaccines, of which global coverage is currently at 60%, far below the 90% recommended target by the World Health Organization. The second category is developing new vaccines that contribute to prevention and control of AMR, like for Mycobacterium tuberculosis. And the third category is expand and share knowledge of vaccine impact on AMR, particularly data collection in low and middle income countries where we're still lacking good data on resistance, and in order to inform how vaccines could avert a proportion of resistance in these settings. So we see that vaccines have mechanisms through which they could avert a proportion of the burden. We can see integration of vaccines into AMR strategies. How does that translate into implementation at the country level? And researchers have analyzed 77 national action plans on antimicrobial resistance, country strategies to reduce AMR, to see how do they integrate vaccines into these plans. And what they had found is that 67% of these national action plans on AMR, they do mention vaccines, but only less than half of them, they actually have indicators that would allow capturing what is the role of vaccines in reducing AMR, indicators that actually allow you to measure and track progress. I think what this means is that there is some understandings of the role of vaccines in reducing AMR, but it doesn't always translate into action and being able to integrate the role of vaccines with AMR interventions. I believe that one of the reasons for that is because there exists a gap, which is the limited understanding as to what extent vaccines can reduce a proportion of antimicrobial resistance. And we are hoping that through the report that I will just go through now, we are addressing that gap. So in this report, we wanted to understand what is the impact of vaccines in reducing AMR and antibiotic use. And we evaluated that impact across 3 criteria. Firstly, what is the vaccine-averted AMR health burden? So how many deaths and how many DALYs associated with resistant pathogens can vaccines avert? Secondly, we wanted to understand what is the vaccine-averted antibiotic use. If we have a vaccine against Shigella, what proportion of antibiotic use associated with treating Shigella could such vaccine avert? And thirdly, what is the vaccine-averted economic burden? So what additional costs of treating drug-resistant infections could be averted by vaccines? And I will go through these results one by one. Firstly, I just wanted to touch on methodology that we used in this report. We started with evaluating 24 different pathogens and 44 vaccines against these pathogens with particular attributes. For pathogens, we included pathogens that are on WHO AMR priority list, pathogens that are highly resistant, or pathogens that are often associated with high use of antimicrobials. 44 vaccines. This is because for a single pathogen, you could have multiple vaccines. For example, Mycobacterium tuberculosis could have a vaccine that is given to infants to protect against pulmonary disease in early life, or it could have a vaccine that could be given to adolescents that are latently infected with tuberculosis to prevent progression to active disease. And these vaccines have specific attributes like coverage, duration of protection, efficacy, target group, etc. This includes pathogens that have existing vaccines, so such as Haemophilus influenza type B, rotavirus, Streptococcus pneumonia. But we had also included pathogens that have vaccines in late clinical development, such as Mycobacterium tuberculosis or Salmonella paratyphi A. We also considered pathogens with vaccines in early development. Here you find pathogens like Acinetobacter baumannii, Group A Streptococcus, Klebsiella pneumonia, or Staphylococcus aureus. And it is often in this group that we find that the WHO AMR priority pathogens, which are often very highly resistant, fall into this category. Secondly, we use data from the Global Burden of Disease study on AMR from 2019 as backbone for our analysis. So we were able to access data from IHME, from the Global Burden of Disease, that is stratified by age, is stratified by syndrome, is stratified by different bacteria, and then analyze that data for the purpose of our analysis, while of course we acknowledge limitations that come with that data, such as limited data coming from low and middle income countries. However, to date, this is the best data set that we have that will allow us to conduct such analysis and make meaningful comparisons to drive and identify priorities. We then developed a static model to evaluate vaccine-averted AMR health burden. The vaccine attributes that we had identified with coverage, efficacy, duration of protection, target group, age group, we had compiled that with the Global Burden of Disease study to be able to estimate the proportion of the burden that could be averted by vaccines. Then, in order to evaluate impact of vaccines on antibiotic use, we had identified additional data on antibiotic use. So these are data from imports to countries. These are data that tell you what is the antibiotic use in hospitals, in communities. We collected data using systematic reviews on syndromes and what is the antibiotic use associated with treating syndromes, and then what is the proportion that each pathogen contributes to that particular syndrome, to be able to understand at the pathogen level, what is the antibiotic use associated with treating that particular pathogen that is causing disease. We then triangulated that data on antibiotic use and consumption with vaccine-averted health burden to be able to calculate the proportion of antibiotic use that could be averted by vaccines. And lastly, in order to identify what is the proportion of the AMR economic burden that could be averted by vaccines, we collected additional data on length of hospital stay. What is the cost of treatment? How much does it cost for a person to stay in a hospital? What is the employment and wage estimates to estimate productivity losses? And we had converted that data, conducted a number of meta-analyses, and developed something that is called AMR Unit Cost Repository, which is a database that tells you for a given pathogen, if it's resistant, how much more does it cost to treat that particular pathogen. And again, we had triangulated that data with the vaccine-averted AMR health burden to be able to estimate what is the proportion of the economic burden that could be averted by vaccines. So firstly, this is the first out of the 4 or 5 slides with the results. This slide shows the potential impact of vaccine on averting deaths associated with AMR. And overall, we see that vaccines have the potential to avert up to 515,000 deaths associated with AMR. And the largest proportion of that impact is in the WHO African region, up to 32% of that burden. And you can see selected vaccines here on the graph on the right-hand side and their impact. If we focus on existing vaccines, we find that they could avert up to 106,000 deaths associated with AMR annually. So this is being able to tap into the full potential of existing vaccines, either introducing existing vaccines like Salmonella typhi in countries where they haven't been introduced, or increasing coverage of existing vaccines like against Streptococcus pneumonia. And the vaccine that is highlighted here with a blue arrow is a Streptococcus pneumonia vaccine, so the vaccine that we currently have. And if we were to increase the coverage of this vaccine to what WHO recommends as 90% coverage level, we could avert almost 60,000 deaths associated with antimicrobial resistance with this vaccine. Then if you focus on vaccines that are in late clinical development, overall they could avert around 135,000 deaths associated with AMR annually. And one example is a TB vaccine that could avert up to 120,000 deaths. And lastly, if we zoom into vaccines in early development, they could avert up to 408,000 deaths associated with AMR annually. An example here is a highlighted vaccine against Klebsiella pneumonia given to infants, which could avert just a little bit over 60,000 deaths associated with AMR annually. So you can see large impact of these vaccines on deaths associated with AMR. Now, if we shift our focus to the second criterion that I talked about, which is the antibiotic use, you can see here that overall, we have estimated that vaccines have the potential to avert up to 2.5 billion defined daily doses, which is a measure of antibiotic use, of antibiotics annually, which it is about 22% of the evaluated burden. So this is for the pathogens that we had looked in our analysis. The largest impact that vaccines could have was in the Southeast Asia region of WHO, almost 40%. And again, if we focus on existing vaccines, they could avert up to 142 million of antibiotic doses. Here, the highlighted example is the vaccine against Salmonella typhi, which is around 45 million doses of antibiotics annually that could be averted with the use of such vaccines in regions that have typhoid. Vaccines in late clinical development, again, example with TB, and here we see that the impact is particularly high, up to 1.9 billion defined daily doses annually. The reason for that is that treating TB takes extremely long, up to 6 months, around 6 months, and requires multiple antibiotics that need to be taken. Importantly, these antibiotics are also quite specific to TB. And if you then focus on vaccines in early development, they could avert up to 548 million defined daily doses annually. And here an example is with group A strep, which is just shy of 75 million doses annually. If we then switch to the third criterion that I talked about, which is the potential impact of vaccines on averting hospital costs associated with AMR, we see that vaccines have the potential to avert up to 30 billion in hospital costs that are associated with treating these drug-resistant infections. And the highest impact of that is in the American region of WHO, almost 30%. This is predominantly because the hospitalization costs are incredibly high in the American region. If we look at the existing vaccines, again, the Streptococcus pneumonia vaccine, $861 million US dollars in hospital costs. Vaccines in late clinical development, again, we have the TB vaccine, 1 billion in hospital costs associated with treating that infection. And vaccines in early development, 30 billion overall in hospital costs associated with treating these resistant infections annually. And the reason for that is a lot of these infections and vaccines that are being developed against these infections are in very early stages of development. So here we have Staphylococcus aureus, we have Klebsiella pneumonia, we have Acinetobacter, we have E. coli that is intestinal and pathogenic. So vaccines that are in very early stages of development, but are highly resistant and have very, very high burden. So then if we want to shift our focus and ask questions, what are the most impacted regions by AMR and where vaccines could play a biggest role in averting a proportion of that resistant burden? The pie chart on the left-hand side shows you the distribution of vaccine-averted deaths associated with AMR across all of the WHO regions, and the color coding legend you have on the top right hand side of this slide. And you can see that the biggest impact of vaccines on deaths is in the African regions, up to 166,000 deaths associated with AMR, almost 33% of the global averted burden, followed very closely by the Southeast Asia region of WHO. For the middle pie chart, which is the vaccine-averted hospital costs associated with AMR, we can see that the biggest impact is in the American region of WHO, which is up to $9 billion in hospital costs associated with AMR. And for the pie chart on the right, which is the vaccine-averted hospital antibiotic use, we can see the biggest impact in the Southeast Asia region, up to 1 billion doses of antibiotics, almost 40% of the global averted burden. So I've shown you some data from the report, high-level data, high-level result, but just to note that there are many other ways that you can look at data within the report. One example is for each of the evaluated vaccines, we had created dashboards that were, in these dashboards, what you can see is what is the burden, AMR health burden for that particular pathogen. What proportion of that burden could vaccines avert? What proportion of antibiotic use could these vaccines avert? And what proportion of the economic burden could these vaccines avert? I've also shared a link in a chat where you can go to a website and play with a visualization dashboard where you can see what is the impact of these vaccines on AMR by different regions. And later, how can I compare different vaccines and which vaccines have lower or higher impact on AMR? So I invite you to have a look and play around with this dashboard. We have also prepared something that we call snapshots for different audiences that we are targeting with this report. And these snapshots, they summarize key findings from the report, particular for this audience that a snapshot is targeting. And they also highlight key recommendations from the report that are aimed at all of these different audiences. We also included a summary of tips for health workers and community representatives to better understand how we can translate that knowledge, translate these modeling estimates into daily conversations with caregivers about vaccines and the potential impact on antimicrobial resistance. So allow me to summarize key results. We found that vaccines have the potential to annually avert up to 515,000 deaths, 30 billion in hospital costs associated with AMR, and 2.5 billion antibiotic doses. If we focus on existing vaccines, they could avert annually up to 106,000 deaths, 9.1 million DALIs, and $861 million in hospital costs associated with AMR. And these vaccines could also avert antibiotic use by 142 million defined daily doses. For vaccines in late-stage clinical development, they could avert up to 135,000 deaths, 5 million DALIs, and 1.2 billion in US dollars in hospital costs associated with AMR, in addition to being able to reduce 1.9 billion doses of antibiotics annually. And lastly, for vaccines in early clinical development, they could avert annually up to 408,000 deaths, 23 million DALIs, and 30 US dollars billion in hospital costs associated with AMR, in addition to reducing almost 550 million doses of antibiotics annually. So what do these results mean, and what are the actions that we need to take in order to tap into some of these resources, tap into vaccines, and use their potential to reduce antimicrobial resistance? Firstly, we need to ensure that the impact of vaccines in reducing AMR needs to be recognized by stakeholders in AMR and immunization. We need to make sure that global, regional, and national immunization strategies and AMR strategies and implementation plans and frameworks, they need to include vaccines as interventions to reduce AMR. Secondly, we want to ensure that the introduction of existing vaccines should be accelerated, like for Salmonella typhi, and the coverage would need to be increased, like for Streptococcus pneumonia. That with existing pediatric vaccines, we should reach the goals of the Immunization Agenda 2030, and the use of vaccines in older age groups should also be considered. What I haven't shown, but in the report you can see, is that if we use these vaccines in the elderly populations, you can also see very high impact on AMR. To prepare for the introduction of newly developed vaccines, the impact of vaccines on AMR needs to be systematically evaluated and embedded into existing decision frameworks. What we mean by that is already at the point where you consider your regulatory decision or policy decision or a decision of whether to introduce and use a vaccine, you could already incorporate that impact on antimicrobial resistance in that decision. And lastly, to enable vaccine development, delivery, and implementation in order to reduce AMR, we need to consider AMR endpoints in research, in clinical trials. We need to develop preferred product characteristics, so describing what these vaccines would need to look like, or identify what are the critical research that would need to be done to accelerate, support the development of these vaccines, particularly those that have particular challenges like biological or technical challenges. And with that, I would like to thank you for listening and hand over to Ivan, who will start the paneling discussion.
Thank you so much, Mateusz, and I hope our audience is still with us after quite a number of numbers. And I think I should also mention that I stand corrected. It's a bit of embarrassment that I didn't mention the week of awareness for antimicrobial resistance, under which this seminar is taking place. So it's actually our colleagues from immunization that remind us that this is the case. So my apologies for failing to mention this. So we're going to have a very nice panel, and echoing on what Mateusz has been mentioning in terms of the relevance of this report to very different audience, we will now discuss with people that come from very different point of view, including donors and partners, including R&D partners, the industry. We'll have also the Global Vaccine Immunization Alliance, SAGE, the point of view of the evidence and strategic advice, and finally, the point of view of WHO implementation. So without further ado, I will turn over to these panelists who will be introducing themselves and maybe introducing themselves as a person, but also introducing their organization in terms of how they see that issue and how they come in the equation. So without further ado, I'd like to ask Padmini Srikantia from the Bill and Melinda Gates Foundation. And the question is, what role does BMGF envision for vaccine and its AMR strategy, particularly regarding investments in vaccine R&D for high-burden pathogen? Padmini, over to you.
Thank you, Ivan, and I must congratulate Mateusz and WHO for launching this report. And to your question, so first, Ivan, I'll introduce myself. My name is Padmini Srikantaya. I'm a Deputy Director in the Global Health Division at the Bill and Melinda Gates Foundation, where I lead our foundation's antimicrobial resistance strategy. So our AMR strategy has always had vaccines as a central component to how we view antimicrobial resistance and the potential to prevent AMR-associated and attributable deaths. And that actually was the starting point of our partnership with WHO back in 2018 to better quantify the impact of vaccines in AMR, and that has led to the publication of this report that we're discussing today. In addition to that, we have supported a number of modeling studies that have been included in the report that you've heard about today. And now going to the next stage, one of the questions I saw in the Q&A was, how does this come to countries? And that's indeed one of our next steps, that we're partnering with organizations like the Global AMR Partnership and One Health Trust to focus on how to bring these data to the country level together with WHO partners and bridge a divide that often exists at the country level between the immunization divisions and AMR national action plans, such that there is crosstalk between both the vaccine decision makers and the AMR decision makers. Then related to our investments in vaccines, I'll split it into two categories. The first is vaccines that are already developed, such as that for pneumococcus and typhoid. And much as what Mateusz described, for example, for pneumococcus, where the data have clearly shown that an improved coverage could lead to additional impact on penicillin non-susceptible pneumococcal strains, as well as reductions in antibiotic use. that is clearly driving our attention, and together with our vaccine delivery colleagues, to support the improvement of coverage of pneumococcal vaccines, as well as investments into higher valency vaccines that are next generation pneumococcal vaccines that may also have greater impact on both pneumococcal disease as well as the AMR potential impacts of such a vaccine. The other example, of course, is in our enterics group with the typhoid conjugate vaccine. And our enterics disease and diarrheal disease group is focused on ensuring that there are catalyzing the data generation to support decision-making at the country level, whether in data to show that the vaccine can protect against multi-drug resistant strains, as it has been shown to do, or that it impacts antimicrobial or antibiotic prescriptions. And that these data can then be used to support vaccine decision-making as well as vaccine rollout in countries. And then finally, to your question related to vaccines in development and currently in research and development. So as with all of our global health decision-making, our vaccine development decisions are ultimately driven by mortality burden. Our AMR strategy has a primary focus on neonates and neonatal sepsis as a population, particularly in low and middle income countries, who are disproportionately impacted by AMR priority pathogens. And in particular, we are most concerned about the role of gram-negative organisms such as Klebsiella pneumoniae and E. coli as key etiologies of neonatal sepsis and related deaths. Data from mortality surveillance platforms done in high mortality settings in sub-Saharan Africa and South Asia suggests that Klebsiella and E. coli together account for, or in the causal chain of, over 50% of neonatal infectious deaths, and Klebsiella itself is in the causal chain of almost 18% of all neonatal deaths. Many of these infections are due to multi-drug resistant strains. So not only are these infections occurring in vulnerable populations who are already at increased risk of infections and poor outcomes, but the fact that these are multi-drug resistant organisms are driving these poor outcomes as well. So for us, we actually invest directly in a Klebsiella pneumoniae maternal vaccine program, which is currently in its early stages, and we're trying to establish biological proof of principle that a vaccine targeting Klebsiella capsular or subcapsular antigens given to a mother during pregnancy can ultimately confer protection to her newborn infant. And then similarly, we're interested to see how potential coverage of E. coli serotypes that are driving the majority of infections can potentially expand this protection and coverage. We are also investors and funders to CARB-X, the Combating Antibiotic Resistant Bacteria Biopharmaceutical Accelerator, and I know Erin Duffy is here as a panelist as well. And we support the vaccine and preventatives arms of CARB-X, where we do see significant and direct investment in vaccines targeting gram-negative pathogens that are causes of neonatal sepsis. So we do have a challenging road ahead for vaccine R&D in terms of development of successful vaccines against Klebsiella, E. coli, and the like. That are not only important causes of neonatal sepsis in low and middle income countries, but are also important causes of AMR associated and attributable mortality in older adult populations and other populations globally. So these are of relevance not only to our AMR strategy, but of course to the global AMR fight. And then finally, I'll just make two other points. One is in our next generation Shigella vaccine development. Similarly, there's an attention given to the importance of antimicrobial resistance, and a value of vaccines effort that was conducted by Path and colleagues showed that actually for stakeholders making decisions about a potential for a Shigella vaccine, the importance of AMR actually helped to raise the profile of the importance of a Shigella vaccine. The last point I'll make is, while we are focused on antimicrobial resistant priority pathogens, I do want to mention also our efforts on viral vaccines, such as for rotavirus and RSV. For now, both, fortunately, we have licensed vaccines, and we know that even for these viral vaccines, not only is there a great potential benefit to reduce mortality and morbidity due to the viral infections themselves, but there may be these additional benefits with improved coverage of reducing antimicrobial use and antibiotic prescription. So we are fully committed to the central position of vaccines in the fight against antimicrobial resistance. Thanks again for your question, Yvonne.
Thank you so much, Padmini, for your perspective. And so now we will move over to the community that works on research and development. And Erin Duffy, I would have two questions for you after you've introduced yourself. The first one would be, how does Carbex consider the role of vaccine in reducing AMR when making portfolio investment? How does the WHO report on the role of vaccines in reducing AMR inform your organization's strategy and investment? Over to you.
Thank you very much, Yvonne, and I will add my voice to congratulate Matheus and the WHO team for this really fine report. Thank you very much. My name is Erin Duffy. I lead the research and development efforts at Carbex. Padmini mentioned us, but I will say again, Carbex stands for Combating Antimicrobial Resistant Bacteria Biopharmaceutical Accelerator. We were created in 2016 for the purpose of, in the case of therapeutics, restoring the antibiotic pipeline focused on AMR, but then to expand to prevention and diagnostics and curate those pipelines as well. We sit early in the drug development or product development chain. Our remit begins really at the early translational efforts and ends after a demonstration of safety and immunogenicity in the case of vaccines in humans. To date, we have not engaged in proof of concept studies. As I said, we do focus on all three pillars of treatment, prevention, and diagnosis, but let me focus today, obviously, on vaccines. We certainly recognize that vaccines can play a major role in reducing AMR in the long term, certainly with their potential to target all pathogens, irrespective of resistance phenotypes and genotypes, and given their overall potential for reducing bacterial burden and antibiotic misuse. Of course, as was pointed out in the report, this is a very challenging area. There have been many failures in the development of vaccines, and many of the pathogens for which we lack vaccines today are considered medium and low probability of success. However, given that this is our role to bring forward from basic science to the clinic and really help in that translation, we do lean into difficult programs. We focus on less conventional strategies as well as both novel modalities and novel approaches to expand the breadth of vaccine approaches and potential products from them. We were very heartened to recognize that the areas in which we have focused our vaccine program and strategy are areas of high importance in the WHO report. From a mortality standpoint, we certainly have had and continue to have a focus on Klebsiella pneumonia, both for maternal vaccination for neonatal sepsis, as underscored by Padmini, but also for other populations as well. Certainly E. coli vaccines, again, with a focus primarily on maternal vaccines for neonatal sepsis. We have supported enteric disease. Our first vaccine in human clinical trials was that of GVGH for invasive non-typhoidal salmonellosis and TCV. Certainly, we have supported, actually for many years now, a novel approach to vaccines for Staph aureus, and very pleased to say that that program, which had begun in the hands of a US-based company, Integrated Biotherapeutics, and now in the hands of Limitech, should be approaching human clinical trials in the very near term. Last year, we held a broad call focused on invasive or disseminated disease caused by Staph aureus and E. coli, again, with recognition of the many failures that have gone before. And so emphasizing very much, again, novel modalities and approaches. And we have brought in and continue to evaluate proposals along those lines. I should say, finally, certainly not from a mortality standpoint, but from a morbidity standpoint, last year we did emphasize vaccines for gonorrhea and have several programs that are advancing towards the clinic. When we look at the main challenges in this space, I think they're really twofold. Obviously, there's a lack of suitable preclinical models that, or at least of unknown translatability to the clinic. As well as then established correlates of protection, or at least the relevant biomarkers that could be adopted to generate proof of concept. This is something that we're actively considering how to affect, whether that's through individual projects or through a step up of portfolio acceleration tools where we tend to fund work that can be used by all teams in our portfolio. The other thing to note is that most of the groups doing this work are very small groups, typically excellent at the fundamental technology, but perhaps not so experienced with the translatability and clinical work necessary to bring these vaccines forward to patients. In that regard, they often don't have manufacturing facilities, et cetera, and so they rely on CDMOs and CROs to do much of their work. We've been considering how to affect this perhaps by engaging directly with CMOs and CDMOs to allow consistent and strong use of them throughout the process. So again, we're very committed to vaccines as part of a 3-pillar strategy targeting AMR. Thank you.
Thank you so much, Sharon. So you've made a few comments to that effect, but I don't know if you want to comment more specifically on what was planned as a second question in terms of the challenges in early clinical development that the developers are facing in vaccine on impact on AMR. Do you think this was sufficiently covered by what you said in the middle of your intervention? Would you like to elaborate a little bit more?
Certainly, I can make very clear my comments. So, a very key question is the translatability of animal models to the clinic. And that is something that we're very active in identifying groups who can help us to shore that up. So I think that's one area. A second area, of course, is the acknowledged lack in the general sense of correlates of protection, or at least biomarkers that can help in the understanding or the comfort with proof of concept, moving into proof of concept. That's a little more challenging, and I think we are taking some steps to understand when, whether, and how challenge models are important, and whether we should support them and in what degree. Or whether we expand, for instance, to focus on that proof of concept efficacy study to then shine a light on potential correlates of protection. Again, we're a little earlier in the process. We tend to support programs at antigen selection through to entry into human clinical trials, but recognizing that there may not be the downstream partners sufficient and necessary to help us bring these products then forward through clinical development, regulatory approval, and market uptake.
Thanks so much, Sharon. And now we're going to switch over to Lucas Krot from IFPMA, who will be also introducing his organization better than I could do. And the question to you, Luca, will be, how does the industry see the AMR vaccine landscape and policy priorities, and how can the recently published WHO report drive progress on your side? I hope you can hear me, because
Indeed,
I cannot see you.
Indeed, I can. I hope you can
Very
hear
good.
and see me
Very well. Over to
also.
you, Luca.
Perfect. Thank you very much. First of all, thank you for the presentation earlier on this webinar and for the invitation. I'm Luca with the IFPMA. We are based here in Geneva and represent the R&D-based pharmaceutical industry, so companies as well as associations that are based, regionally or nationally. So I think one thing that I really want to say up front is, I've been in this space for a couple of years now, and we've been working with our sort of companies as well on the topic of vaccines for AMR, and it's just really exciting to see how far these discussions have come in the last several years, in no small part also due to the work of the WHO on this. And we've seen also, this year, especially in the multilateral space, like in the high-level meeting on AMR declaration, really increasingly concrete and specific language on vaccines for AMR. One specifically that I recall was talking about the importance of integrating AMR national action plans with national immunization programs, which really I think has been stressed many times as absolutely crucial. Now, there are sort of three kind of insights I want to share up front before going into maybe slightly more detail on the kind of policy aspects that we've been thinking about, as well as the report recommendations. The first one is that in the context of the work that we've been doing, we also several years ago supported the development of a report by CRA that looked at different national action plans on AMR across different WHO regions, and specifically, how are vaccines positioned in those national action plans. And the report itself found that there's quite a strong variance between sort of different countries, different regions. And now, looking again to the outcomes of the high-level meeting on AMR from September and the foreseen AMR Global Action Plan revision, the original one of which is from 2015, does also present an opportunity to really, think about kind of strengthening the language and concrete guidance on how vaccines could be used as part of strategies to address AMR. The second point, I think, relates to how in just, last couple of months, following on from the initial Graham AMR burden research, there was a follow-on report published that looked at the historical data from 1990 onwards, as well as projected burden to the future. And one of the interesting points in there was that kind of looking by age groups, the AMR rates in children have dropped, I think, by over 50% in the last 30 years, while the AMR rates in the elderly have been conversely growing. And this reduction in AMR rates in children was also in part attributed to vaccination programs, which does indicate that perhaps adult immunization or life course immunization could be an underutilized approach. And we also did some work on this, trying to better understand the broader socioeconomic value of immunization earlier this year with a report that was published by the Office of Health Economics that showed that adult immunization can yield a 19-fold return on investment. And third point is more on the R&D side, and I would go here back to the WHO clinical pipeline report on vaccines and in clinical development, which, several pathogens, the high priority pathogens, have a very thin pipeline, even then predominantly in phase 1 or phase 2, and for some, there's nothing in development really. And the report also acknowledged the sort of role of the private sector in R&D, given the challenges, the risks associated with it, and that again here when we're dealing with for example vaccines against priority pathogens, there's also lack of clarity on target populations, how will these vaccines be used, and all of that presents additional challenges. So in summary, kind of reflecting on these three areas, one of which can be thought of as more AMR/immunization strategies, then the uptake piece, then the R&D piece, we really see kind of three overall policy areas as crucial for further development among all involved stakeholders, which would include, as a number one, regulatory guidance and development support for AMR-relevant vaccines, including guidance on sort of measurable indicators, modeling approaches that can be used to determine additional vaccine value. Of course, early dialogues and appropriate pathways for that in the development of these vaccines will also be important, as well as potential regulatory incentives and targeted funding support for AMR relevant vaccine development, and colleagues before me have spoken about that as well. We need to find ways to really capture sufficiently and in a kind of standardized manner the additional value that vaccines provide in the fight against AMR. That the WHO report that came out just last month really, I think, does a great job of modeling out and providing additional considerations across a wide variety of scenarios that I think warrants further sort of look at as well. And that kind of alignment between, as I was saying just earlier, between the sort of regulatory side as well as then, HTA bodies and NITAGs will also be important. And finally, we shouldn't, I think, neglect the importance of surveillance. And WHO, I know, already is doing, work on that, for example, via GLASS, because with appropriate guidance on surveillance systems and the data that surveillance systems should capture, it can also really help us understand from a real world perspective the impact of vaccines on various sort of AMR relevant indicators, including infectious disease burden, including antimicrobial use, and more kind of what happens before you have a vaccine in place and what happens after you've introduced the vaccine. And again, we really really welcome the report of the WHO on this topic, the estimating the impact of vaccines in reducing AMR and antibiotic use. And sort of the new thinking, the data and the modeling that it provides. The key recommendations will be really important to sort of, continue discussing in the coming weeks, months, and we are certainly more than happy to be part of those discussions. We do already, see sort of further opportunities to really drive these discussions forward and continue building on the progress. Which, kind of going back to the some of the initial points that I raised, would be to increase importance and further build the case for life course immunization, right, / adult vaccination in the context of reducing also AMR burden. And I know that the report provides in many cases several kind of modeling scenarios, which in some cases looks at different sort of target populations, right, including in some cases again the kind of looking at all age groups, right, and what's the benefit that you get from that. Then on AMR surveillance, there certainly is potential here to provide sort of best guidance to countries on kind of AMR tailored surveillance in a way that really helps demonstrate the value of an impact of these vaccines and help then inform decisions around utilization and recommendations and introduction, and also in part support the case for investment for development. And finally, I think the really important point here to reflect on, and as a something that to sort of help with the follow-up would be how to sort of align these discussions, right? The work that the WHO is doing, for example, with the SAFE Secretariat, with the Regional Immunization Technical Advisory Groups, NITAGs, the global NITAG networks, and the support that WHO also could provide here, right, with information sharing sessions, kind of really ensuring a kind of joint and common understanding of the vaccine impact on AMR. So I would stop there and back to you, Ivan.
Thanks so much, Luca. So I think there's a certain direction of travel in the way that this webinar was planned from the donor side with the Bill and Melinda Gates Foundation. Then we've seen the point of view, the R&D rather upstream, and then now the industry. Now we'll move forward more towards the implementation side with Nidhi Jadeja from Gavi. And my question to you, Nidhi, would be how is Gavi approaching the prioritization of new vaccine that could play a role in AMR reduction? So in other words, when you have your framework of evaluation of new vaccine, when Matoush come with all these additional endpoints in terms of antimicrobial use and etc., how do you factor that in, and how are you ready to receive that kind of evidence? Over to you, Nidhi. And of course, if you can briefly introduce yourself and Gavi, that would be awesome. Over to you.
Thank you, Ivan. In short, we use them when materials comes to us. So congratulations and thank you to Matthias and WHO for this huge and important undertaking. My name is Nidhi and I'm on the policy team at Gavi. So as Ivan described, we are at the other end of the R&D spectrum. While we have an interest in what's going on in the pipeline, our role is really focused on the introduction, scale-up, and distribution of vaccines. So we're an alliance at Gavi. This means we're a global cooperation mechanism providing vaccines to those who need them the most. And our mission is really about both introducing new vaccines as well as improving access to existing ones. And to give you an idea, we currently buy vaccines for about 60% of the world's children. So with a growing number of vaccines in the market and many more in development, how does Gavi decide which vaccines to support? This is done through our vaccine investment strategy, or the VIS, which is led by the policy team here at Gavi. And it is an evidence-based, systematic process that happens every 5 years, although unless there's an urgent public health threat or a breakthrough in R&D, which demands a VIS to happen before that. And what the VIS does is it evaluates vaccines using a transparent framework that considers criteria like health impact, value for money, equity, climate change, and since 2018, their impact on AMR. So for this year's VIS, we worked very closely with WHO and Mateo's team to align with their efforts on the impact of vaccines on AMR, and therefore framed our analysis for the criteria in the VIS in a very similar way to that of the value attribution framework. And we also relied heavily on the work that was commissioned by WHO to input into our analysis. A key difference was that the weighting for each factor under the AMR criteria was slightly different. We used an approach based on expert consultations that we conducted, but otherwise it was very reliant on this WHO analysis. And overall, the challenges and limitations that we encountered would mirror that of what was found during the generation of the report, in that we really need more robust country-specific data on morbidity, mortality, healthcare costs due to AMR, and antibiotic usage to strengthen the modeling and the evidence basis for decision-making for the next VIS. So in June, the Gavi board approved the VIS, which includes future vaccine programs and learning agendas for TB, adolescent vaccines, GBS and dengue, as well as global stockpiles and learning agendas for vaccines against Mpox and Hep E. And these decisions really included the consideration of the impact of these vaccines on AMR as a modulating criteria. So it was a major policy decision on new vaccines at Gavi, considered the role of vaccines in addressing AMR. So we very much like to thank WHO for leading on this work, for allowing us to lean on this work. And we're looking forward to working with all partners concerned to really advocate and strengthen both the evidence basis and the use of vaccines for AMR. Thank you.
Thank you so much. I guess the proof is in the pudding. You've already done it and you already take that into account. So that's very clear. Thank you so much. So we're now going to move to Kathleen Neuzil, who is a member of SAGE, and maybe it would be also useful if you could explain to our audience what SAGE does with WHO. And my first question to you would be, how does the policymakers consider evidence for the impact of vaccines in reducing AMR when making a policy recommendation about vaccine introduction and use? Over to you, Kathleen.
So thank you. I'm the director of the Fogarty International Center at the National Institutes of Health. But as you have said, I am representing my role on the Strategic Advisory Group of Experts on Immunization for WHO in this capacity. And just want to acknowledge Matus and all of the prior panelists who have set me up nicely and made my job very easy. I also note from the chat a number of NITAG members, a number of policy members at the regional level. So they will understand some of these concepts as well that I'm going to lay out. And obviously, when we're making decisions on vaccines, we have several considerations: the magnitude of the problem, how common is the illness, how severe is the illness, does it cause outbreaks, does it occur in epidemics that might be disruptive, does it affect healthcare workers, which they then may have downstream effects on delivering care. Of course, we look at safety and efficacy, at cost effectiveness, at delivery, at equity, many of these considerations that you've already heard. So just using the example of drug resistance, of AMR, and how we might incorporate that. Obviously at the burden of disease level, we heard this in Matus's presentation, a pathogen that is resistant to antibiotics can lead to more morbidity and more mortality. So the severity factor. It can lead to more disease overall, even if it's not severe, and it can lead to more antibiotic usage. And I saw someone in the chat talked about viral vaccines, and that's true of viral diseases too, because we don't always use antibiotics appropriately. Cost is another consideration. And again, both the cost of a more severe illness that might lead to a hospitalization, a prolonged hospitalization, or the cost of a broader spectrum antimicrobial can both increase the costs. And then we haven't really talked a lot about equity. And I think equity is really important, because frequently many of these diseases, and typhoid is a good example, affect poor populations or marginalized populations. And so it's really going to affect the disease and the disease morbidity with the antimicrobial resistance. It also affects, again, the cost of antibiotics, which may not be affordable to certain populations. So I think a recent example of where SAGE used the issue of antimicrobial resistance in a policy was for the typhoid vaccine, where very specifically we say that countries endemic for typhoid should introduce vaccine. Vaccine should be prioritized in those with the highest burden and or those with the highest burden of antimicrobial resistance. So recognizing that we have multi-drug resistant typhoid, we have extremely drug-resistant typhoid, it's becoming very difficult to treat, and so was an impetus, for example, for Pakistan introducing typhoid vaccine through a campaign because of their extremely drug-resistant typhoid. So I think that if we want policy to be able to focus on AMR, then we need to adapt our frameworks. For example, SAGE uses the PICO system, the policy question, to guide our collection and assessment. So population, intervention, comparison, outcome. So we need to be sure that antibiotic usage and outcomes of AMR infections are part of that PICO evaluation. Data on AMR needs to be collected. Data on antibiotic usage needs to be collected when we're designing clinical trials, when we're looking at post-marketing surveillance. Padmini said this earlier, but after that introduction in Pakistan, we were able to show that the typhoid conjugate vaccine does reduce extremely drug-resistant typhoid. Those are important. And finally, the equity component. I don't believe that even our categorization of AMR or XDR translates well to the clinical or policy space, because you may have an organism that is categorized as multi-drug resistant, but that population has access to drugs that it is sensitive to. Whereas if another population, and this gets to the equity, does not have access to those other antibiotics, then essentially you have a difficult to treat or impossible to treat infection in certain populations. So I would encourage us to think about the way we talk about AMR, to consider this access to antibiotics and equity issue at the more micro population level. And finally, we've heard this throughout, but really the greatest inequity is data inequity. If we don't know where there's AMR, because we don't have the capacity to do blood culture surveillance, for example, or other surveillance, then we have no information to guide us. So surveillance is important, diagnostics are important, and again, it's important at the local level, the regional level, to guide policymakers. Thank you.
Thank you so much. So that's job on my side because I'm supposedly in charge of surveillance, prevention, and control. The point is taken. Thank you. We're working hard on this. So I had another framework that we're running a bit short of time, and you covered some of that. But we had another question for you in terms of how can policy framework adapt to systematically consider data of impact of vaccine in reducing AMR? I have the impression you covered that quite a bit. Would you have additional comment, or do you think we can move on?
I think we can move on. I think I
Okay.
mixed the two, but again,
I have the
just
impression, yeah.
being explicit about
Mhm.
incorporating these measures of AMR and antibiotic usage.
Definitely, and I think Matoush also has been very good and very clear in his guidance, and there's more tools coming, which we're all looking forward to. So really now downstream, we have a colleague from WHO Zimbabwe who will more at the implementation side make some comments on how immunization with the typhoid and cholera vaccines impacted the prevalence of drug-susceptible and drug-resistant typhoid and cholera in Zimbabwe. What lesson can be learned from this experience? And this comes from Tapfumane Mashe from WHO Zimbabwe. Over to you, Tapfumane.
Thank you so much. Can you hear me?
We can hear you loud and clear. Over to you.
Okay, thank you so much. I think there's a bit of background noise where I am, but let me just contribute to the question. So maybe just to give you as a background, Zimbabwe is one of the countries which my previous speaker said that it was endemic, or it is endemic to typhoid. Because of the typhoid cases in Zimbabwe, we was like, just to give you as a background, the typhoid cases started in 2009. And from 2009, we
Hello?
Mashe, I think we lost,
we lost
Mashe,
you, I think.
hello.
Is it only me?
Yeah,
no.
yeah.
Mashe, we
I'm
lost you.
back. Can you hear me?
He's back. Yes, we can
Yes.
hear you. Go ahead.
Yeah. So sorry. Yeah, where I am, network is bad, and also there's a bit of background noise. So I was just saying that typhoid has been an issue in Zimbabwe from 2009, and because of what we did, we have been tracking typhoid from 2009, checking if the antibiotics that we're giving people that contract typhoid were still working. So we've been doing surveillance of typhoid, though at a lower scale, I think because of issues of blood culture. We don't have a lot of the facilities that offer blood culture services. But we've been tracking the emergence of typhoid for about 5-6 years. So what we discovered was that initially the organisms were susceptible to ciprofloxacin, but over time it changed. Then we ended up having the cipro-resistant typhoid, which we called the MDR typhoid back then. So in 2008, we had an outbreak of this drug-resistant typhoid, and there were so many cases of this typhoid happening in Harare. So what we did, a combination of cases and also a combination of MDR typhoid in the Harare city, we asked Gavi to support us so that we can introduce TCV. So TCV was introduced in Harare in 2018, 2019 to mitigate this outbreak of typhoid that was happening in Harare. So for us, we're killing one bird with two stones. One was the issue of MDR typhoid. Secondly, it was the issue of incidence of typhoid, which was high because of just from the month of August to the month of October, we had more than 5,000 cases of typhoid affecting the general population, and we had about 15 deaths that occurred during that period. So from there, we have been tracking typhoid in terms of resistant patterns and even also the impact of TCV. So I've been doing a study which has now maybe lasted for more than 10 years now. So what we did, we've analyzed the cases that were occurring before the introduction of TCV and cases that are now occurring after the introduction of TCV. So because of the first introduction, which was a campaign during an outbreak, the government of Zimbabwe ended up suggesting that let's have typhoid as part of the routine immunization vaccine. So just to give you statistics, we have seen a decrease in number of cases that happened before the introduction of TCV, and now that is now happening after the introduction of TCV within the people that got the TCV initially. So the TCV that we gave people initially, it was between 6 months and 15 years. So within that age group, we have seen a very tremendous reduction in cases of typhoid before TCV and after TCV. Then another interesting observation that also picked was that because the focus of this TCV was focusing on the six months to 15 years. Then we've seen also a reduction of cases among the people that didn't receive the TCV, which is the 15 years, the 16 years and above. So in terms of the data that we now have, we have seen that TCV works so well. It has reduced morbidity. It has even reduced mortality for typhoid cases. For this year only, we have maybe picked not more than 20 cases, but previous years, we used to pick 5,000, 6,000 cases of typhoid. So that's one a good example that I can share to say we have seen the impact of TCV, its introduction in number of reduction of cases. And that's also another interesting part which I can share from the lab side is that when we are now testing TCV, when we are now testing typhoid, that we are currently picking, the small cases that we are picking, they are also susceptible to ciprofloxacin. We are still monitoring to check if there is any link between the one that we are getting and the one that we are now getting in terms of genomics. We're also going to do some genomics work to check the genomic structure of the typhoid cases that we are getting before introduction of TCV and the one that we are now getting, which are now cipro susceptible. Then in terms of cholera, we record cholera cases or cholera outbreaks after every maybe 2 years or 3 years. So in 2018, unfortunately, we had a very big cholera outbreak, and this one was caused by a mild drug-resistant cholera, Vibrio cholerae, which was resistant to almost all the drugs. And the drug of choice that we ended up using was azithromycin. But because of this more drug-resistant cholera, we also ended up introducing OCV, which is the oral cholera vaccine. And this managed us, or this helped us to mitigate this outbreak. As we speak, we have recorded a few cases of cholera in one of the cities, and we are also introducing this OCV again to mitigate this outbreak. So in a nutshell, we have seen the great impact of TCV and OCV in our day-to-day work as a country. And we are happy to say that these results are going to be available to the general public to really measure this impact which has been experienced in Zimbabwe. Over to you.
Thank you so much. That was very clear, and I personally appreciated a lot the way, again, we've gone through the whole life cycle from the role of the donors who have the capacity to set the whole portfolio of investment and research to landing all the way to the country level, where these vaccines are actually put to use to prevent disease and including disease from drug-resistant pathogens. So I believe our colleagues have been exceptionally active in typing responses in the chat to the numerous questions that have been coming up, but that there's a few maybe residual questions that would benefit from short, cogent answers from some of our panelists. So one of them is, what is the role for combination vaccines in reducing AMR? Matush, would you like to take that one shortly, as it is now 4:30 in Geneva?
Sure, I'll be happy to do that. And just
Thank
very
you.
shortly, it's very important to consider how we can deliver all of these vaccines that we promote in the report on vaccines and AMR. It's very unlikely that we'll be able to have all of these vaccines and deliver them at once. Countries are already facing challenges with having multiple immunization sessions, and then within a session, delivering multiple vaccines into children. That's very challenging. Because of that, in order to address it, one solution could be combining vaccines. That could reduce costs of visits, costs of immunization. That could save health workers time. But from the AMR perspective, it could help to, for example, combination vaccines could start focusing on preventing a particular syndrome. If a clinician knows that a large proportion of a syndrome is prevented, averted by vaccines, bacterial vaccines, then that may change the prescription patterns and then reduce the consumption of antibiotics associated with treating that syndromes and hopefully impacting reducing AMR. To better understand what combination vaccines need to be developed, multiple factors will need to be taken into account to understand the feasibility of combining these vaccines. And this is one of WHO's priorities going forward, together with partners like from PATH and like from pharmaceutical industry, with support from the foundation. So we'll have more information about that. We had recently published a Lancet publication that I'll put in a chat if you want to find out more.
Thank you. And there's another one that probably deserves a little more development because it's not that obvious. So what role could viral vaccine play in reducing antimicrobial resistance? Padmini, would you mind taking that one, please?
Sure, Ivan, my pleasure. So the potential role of viral vaccines in addressing AMR, I think we should think of it in three potential mechanisms. One is to reduce antibiotic use or antibiotic prescription. So a vaccine targeting a viral illness such as influenza, RSV, rotavirus. We do know that there are antibiotics used to treat these viral illnesses, even if they may not be effective, but certainly for the types of syndromes that affected individuals present with lower respiratory tract infection or diarrheal illness often result in antibiotic prescriptions. And so viral vaccines targeting these viral pathogens can help to reduce these unnecessary or inappropriate antibiotic prescriptions. The second is, of course, that a vaccine targeting a viral pathogen, such as influenza or RSV, in itself, by reducing RSV illness or respiratory disease or influenza, can also help to reduce the incidence of secondary bacterial infections, which in and of themselves can be due to both susceptible as well as resistant bacteria, and also can subsequently lead to additional antibiotic prescriptions. The third is by suppressing resistance evolution and reducing the transmission of resistant pathogens. So we know that many of the bacteria that are, when antibiotics are used for a viral syndrome or a viral illness, the bacteria that are colonizing a person experience what we call a bystander effect, that the selection of resistance is seen in off-target pathogens. So whether the pathogen targeted for the antibiotic prescription is appropriately done so or not, the bacteria that are colonizing the nasopharynx or in the gut may experience this off-target bystander effect. And by reducing that this off-target bystander effect, you may actually also help to reduce the evolution of resistance. The data that we have seen, certainly from higher income country settings in influenza vaccine for the use and improved rollout of effective influenza vaccines, have been quite impressive, ranging from anywhere from 20 to over 50% reduction in antibiotic prescriptions during the influenza season, particularly depending on how effective a vaccine is in a given season. And more recently, we've seen with the rollout of long-acting monoclonal antibodies against RSV, nirsevimab, for the treatment, or rather the prevention of RSV in young infants, The data from nirsevimab's effectiveness study in Europe showed a 24% reduction in antibiotic prescriptions as well. And then last, I'll mention rotavirus, where we know that rotavirus from multiple studies in lower income geographies is responsible for about 31% of the antibiotics prescribed for diarrheal illnesses. And even at current coverage levels, has been estimated in modeling studies to be responsible for averting 13.6 million antibiotic-related illnesses. So we do know that there are compelling data out there for the potential impact of vaccines targeting viral pathogens, both on antibiotic use, as well as these downstream effects. Perhaps the last thing I'll mention is one thing we haven't mentioned so far is, as we see the reduction in antibiotic use, there's also a benefit for the microbiome as well. And this is not something that we have well quantified, but I think that we should also keep this in our potential metrics of the benefits of vaccines to address AMR as well as overall health of the population. Back to you, Ivan. Thank you so much.
Thank you so much. And my job at this stage is to close as soon as possible so that we stick to time, and also out of respect to our interpreter. But allow me first to thank Matoush and the Department of Immunization, Vaccine and Biological, number one, for a fantastic report. And number two, that as we've just seen is very useful to a wide range of stakeholders. Number two, for convening this webinar, for which we've had really the opportunity of listening to people all along the sort of value chain, from agenda setting, from research point of view, down to the implementation in Zimbabwe. So really, thank you for your contribution. Thank you also to all the participants with incredible question and lively participation that has led to massive amount of typing by our panelists. So really, thanks to all of you, and wonderful morning, afternoon, evening, or night, wherever you are from the 4 continents that from which this webinar was brought to you. I think we had people from all over talking to people from all over. Bye-bye.
Thank you so much. Bye.
Bye-bye.
Thank you. Bye-bye.